Good afternoon. Let's make sure I'm okay. Good afternoon and welcome to our 12:30 to 1:30 p.m. session on opioids and the impact that COVID has had on drug use and abuse, presented by Dr. Bo Clark, EBR coroner. After having received his Doctor of Medicine from Louisiana State School of Medicine in New Orleans, Dr. Clark has served as EBR Parish's coroner since March of 2012 to the present. With a list of publications, awards, and professional certifications, Dr. Clark will provide clarity on why the epidemic of opioids and heroin has occurred and what are some possible solutions in addressing this crisis. Please place your comments and questions in the chat to be addressed at the end of the presentation. Please also remember to complete the evaluation immediately following this session to receive your certificate. Lastly, contact the eye care office if you have any questions regarding your certificate. I present to you Dr. Bo Clark.
Great. Thank you, Dana.
You're welcome.
Good afternoon, everyone. I'm Dr. Bo Clark. I'm the East Baton Rouge Parish Coroner, and I'm here today to talk to you about our opioid epidemic. And certainly we can all recognize over the past year, our lives have been consumed with the COVID pandemic, but it's the opioid epidemic that really has been going on much longer than the pandemic, and is certainly wreaking havoc and causing many tragic deaths in our community. So I start out, and you can see my bio here, and to let you know that before I became the coroner, I worked for the East Baton Rouge Parish Sheriff's Office on the SWAT team, and we would often do high-risk warrants, or basically drug warrants, going into homes on drug raids. And I can tell you the time I spent, about 10 years doing that, not once ever did I see heroin. We certainly had a lot of cases that involved marijuana, a lot of cases that involved cocaine. We had some pill cases, but never ever once did I see heroin. And the reason I share this story with you is because we flash forward to 2012. And in 2012, as the coroner, I investigated 5 deaths that were related to heroin overdose. And certainly this was very perplexing to me, going from an environment where I never saw heroin ever in East Baton Rouge Parish. And now all of a sudden, we were having people die as a result of it. So I'm going to take you through kind of the genesis of the epidemic, which in my opinion began in 2012 when I first sounded the alarm. And we'll move through what caused the epidemic into all the way through to what we can do about it. And then we'll finish up a little bit what happened in 2020, especially as it relates to the COVID pandemic. The slide you see on your screen right now is a slide about heroin. Heroin is an opioid painkiller. It is only used for recreational purposes because of its euphoric effects. One of the major side effects, however, is it causes central nervous system and respiratory depression. Both of those two things can lead to someone's death. The picture you see in the bottom left hand of your screen are the 3 forms of heroin. One is called black tar heroin because it's black and it's tarry in substance. The other one is kind of a white powdery substance, but the most common form we see in it is the brown, sandy looking substance. And when I say sand, I know a lot of people here in Louisiana vacation in Florida, maybe go to Destin. This is nothing like Destin sand. It's more like Biloxi sand with that kind of brownish to that. So if we have anybody on the conference that's from Mississippi, or you travel to Mississippi, you'll appreciate the type of sand I'm really talking about. On the right at the bottom of your screen is a needle and a spoon. And that is there to remind us that the most common way we think about heroin, probably because what we see on television and in the movies, is someone injecting a vein after they've drawn the heroin up in a needle and a spoon. But as you're going to see later in today's lecture, there are other ways that people can ingest this drug, not just with a needle and a spoon. So next slide, please. So postmortemly, when we draw toxicology, and that's looking at people's urine and blood, we never, ever, ever find heroin in their system. And that's because heroin almost immediately metabolizes into a drug called 6-monoacetylmorphine, or 6-MAM for short. The only thing that turns into 6-MAM is heroin. So if we find 6-MAM in your blood or your urine, it gives us a clue that the parent drug was heroin. And it's also important to understand that when we do look at blood and urine, oftentimes we will find people with massive amounts of 6-MAM in their blood and no 6-MAM in their urine. And that gives us a clue and tells us that the person died very rapidly because they didn't even have a chance to get the drug into the urine. Other times we'll find 6-MAM in the urine, but not in the blood. And that tells us that the individual died very slowly, meaning that respiratory depression, that central nervous system depression occurred over a long period of time. And that's why we're seeing that phenomenon. Next slide. Two important pharmacological concepts that I think you have to understand before we move any further. The first one is something called potency. And that basically says that a drug has a certain amount of the drug in it, and that milligram dosage of that drug is verified for giving its effect. For example, if you were to get a Motrin or an ibuprofen or an Advil right over the counter, that one pill has 200 milligrams in it. It's gone through an FDA process. It's assured to have that amount. Now, despite what you might think, when it comes to illicit drugs like heroin, and later we're going to talk about fentanyl, drug dealers do not go through any kind of FDA process to determine the potency of their drug. As a matter of fact, they most times don't know. And if the drug dealer doesn't know, that means that the person who's having an addiction problem won't know. And they can get a variance in the amount or how potent the drug is. We have seen potencies in seized heroin in this parish between 12 and 47%. And recently, actually, have seen it even higher than that. So you can imagine if someone is not used to using heroin because they've never done it before, or they are maybe using it for the first time, or maybe they're using something they think is another drug and it ends up being heroin. If it has a high potency, it can get the person in trouble, and they won't be able to manage that medication. And unfortunately, some of those circumstances, they die. Next slide. Tolerance. So the next pharmacological concept for you to understand is something called tolerance. And this is somewhat specific to opioid drugs. And so what you might have heard before is if somebody said, yeah, the doctor gave me a pain pill and I used it for a couple of days and it just didn't work. It didn't give me the same pain relief effect that it initially did. So what did they have to do? They had to take 2 of them, or they had to take an increased dose, or they actually had to go back to their doctor and get a different, more powerful opioid. And so tolerance, when it's specific to opioids, is something that develops over time. And so first-time naive users versus chronic users, there is a difference between how these individuals can react to the tolerance that they've developed when it comes to opioids. Next slide. So the 2 situations we see most commonly are someone gets instant death and they're a naive user, meaning they've never had or had very little opioid in their life, and all of a sudden they attempt to try these drugs, especially the illicit ones. They're unaware of its potency. They don't have a very high tolerance, and of course they get into a scenario where even a low potency drug can cause death. Another scenario we oftentimes see is that instant death occurs right after the person has left rehabilitation. So while they're in rehabilitation, they're no longer receiving that opioid. Their tolerance levels then decrease, sometimes even to the naive state. And then when they decide to use again, they are not knowing what the potency of the drug is. They're just using a volume of drug. And when you use that volume of drug, it ends up being too potent and they die as a result of it. Next step. The most common form of drug overdose that we see in East Baton Rouge Parish is something that's called multi-drug toxicity. This accounts for almost every drug overdose or almost all drug overdoses that we see. And what this means is that the person actually takes a combination of drugs, and the combination of the drugs is what leads to their death. Now, we oftentimes will see the individual will take, if they like to abuse stimulants, they'll abuse just stimulants, meaning methamphetamine, cocaine. Or on the other hand, if they like to abuse depressants, they will use the depressant categories of drugs, which include the opioids, of course, but they'll also mix that with benzodiazepines like Valium, Xanax, Ativan. They might throw in there a muscle relaxer like Soma, and then they might actually also use alcohol, which is a depressant as well. And it's the synergistic effect of all these drugs that cause that depression of the respiratory system. But the main culprit is the opioid because it's the most powerful of all of them. It's very rare for someone to ingest one drug and die as a result of it. So like I said at the very opening here, what we see is we're going to look at our heroin and opioid epidemic in graph form. As you'll recall, in 2012, we had our first year where we saw 5 heroin doses. The following year in 2013, that number grew to 35. And you can see all the way through 2019, and what's listed on the screen are the heroin drugs, is kind of the graph and how it, right, if you hit the button one more time, it'll give us our totals. There you go. So overall, this is what the graph looks. In 2012, you can see how we had 28 total overdoses, 5 of which involved heroin, but the majority of each one of these columns involves multi-drug toxicity as a result of opioid drugs being the most common, meaning depressant abuse. We still have a few drug overdoses annually that involve stimulant abuse with cocaine and methamphetamine, but you can see we reached an all-time record high in 2019 of 127. Now, I'm here to tell you, not all the numbers for 2020 are currently in, but as of today, we have 236 overdoses in East Baton Rouge Parish, nearly doubling the 2019 number, with still several cases that are pending toxicology, which should come back over the next couple of weeks. So we have a very deadly, a very tragic year in the world of overdoses, specifically opioid overdoses here in East Baton Rouge Parish just last year in 2020. Next slide. So as a scientist, as a physician, when I saw this and we went from that 5 overdose number to 35 in the first 2 years of the epidemic, I had to ask myself the question, why? Why all of a sudden did I spend so many years doing narcotics warrants for the sheriff's office? Then I become coroner and we have people dying of heroin when we never saw it before. So in my research, what I discovered was a couple of things happened. Number one, the law changed. The Louisiana legislature in the early part of 2000 was looking at mandated life sentencing. At that point in our laws, if you were caught and convicted of selling Schedule 1 narcotics, you would get 99 years or life in prison, which essentially in Louisiana means that you get life in prison. In an effort to reduce this, because they actually felt they had too many people selling marijuana in jail, and marijuana is still scheduled as a Schedule 1 narcotic, they decided to amend the law and take it from the maximum sentencing of life in prison all the way down to the bottom, which was 5 to 10 years. And in doing so, 5 years really equates to about 18 months. So essentially, by changing the law for the distribution of Schedule 1 narcotics to try to reduce the number of marijuana dealers that were in jail, we ultimately created an issue because Schedule 1 also includes heroin. And so essentially what we did by changing this law is we invited heroin dealers, inadvertently invited heroin dealers to sell drugs or heroin in the state of Louisiana. And so they could come here, and if they got caught selling this heroin, which we know is very deadly and can kill people, they would get very minimal sentencing. The second thing that happened in 2010 was the Louisiana Board of Pharmacy, along with boards of pharmacies across the United States, implemented programs that were in an attempt to stop what's called doctor shopping, or the diversion of prescription narcotics. And we've all heard of the term doctor shopping, and the way they chose to combat that was to create this thing called the Prescription Monitoring Program, the PMP. Basically, the PMP is a database on a person's narcotic prescription history. And as a clinician or a prescriber like myself, if you were to come see me in the emergency room and you had some kind of obscure complaint that might need pain medication, before I would just, with a knee-jerk response, write you a prescription for opioid pain pills, I could look you up in the database and determine how many prescriptions and how often you were getting these prescriptions. So sure enough, if I found that you had been to the doctor several times in the last couple of days and had gathered prescriptions from each one of these doctor visits, then I would not write the prescription. Ultimately, what happened in 2010 over the next couple of years is you saw this plethora of prescription narcotics that were being sold illegally, diverted illegally on the street, began to dry up. And when they became less and less and less, waiting in the sideline was the illicit drug heroin. And so when an opiate addict could no longer get their opioid prescription from a prescriber, then they would turn to the street. When they no longer could get it from the street because the supply of opioid prescription pills was no longer there, then they would turn to illicit heroin. And you could see how that would create a pretty significant issue, especially for someone who is addicted to these medications. Next slide. So more of the why. was something that occurred called the invention of the fifth vital sign, what we commonly refer to as the pain scale. Now, this has a pretty interesting genesis. There was a pharmaceutical company named Purdue Pharma who said that we were undertreating pain as clinicians in this country. And we were undertreating it so much that they wanted to create a mechanism by which we would address people's pain. And what they did was they created something called the pain scale. And they gave it so much importance that they referred to it as the fifth vital sign. And so we know, of course, vital signs, just by their name alone, make them very important. But we're talking about things like your pulse, your respiratory rate, your temperature, and your blood pressure. All four of those vital signs are measured and calculated scientifically. You either count them or use some like a device like a blood pressure cuff or a thermometer. However, we're giving so much importance to this fifth vital sign called the pain scale that we were not only then required to record it, but it was the first and only vital sign that is not objective in nature, it's subjective in nature. Meaning that if you went in and you said, well, what's your pain? And somebody says, well, I have a 3 out of 5, 3 out of 10, then, your 3 out of 10 and someone else's 3 out of 10 can be completely different. And there's no science based on this. This was just how you were feeling. But nonetheless, we implemented this throughout our nation. And then it became the process of every time you went to see a clinician, what were they asking you? They were asking you what your pain was, and you had to rate your pain, and we had to document your pain. Furthermore, it got so bad that not only did we have to document your pain through the pain scale, but then as a clinician, I was required to respond to it, to write you a prescription so that I took you from a 7 down to a 3. Lo and behold, the irony here is this pharmaceutical company, Purdue Pharma, who created the fifth vital sign, created the pain scale, and furthermore convinced the federal government that it was necessary and should be mandated in its use across the country, said, well, no problem. If the person complains of a high pain scale, then you can use this drug that we've invented. It's called OxyContin. And by the way, it's not addictive, so there's nothing to worry about. Now, lo and behold, what we found out later is that was a lie. OxyContin is highly addictive, and a lot of people became addicted to opioids because of a prescription from a clinician, namely OxyContin. So another reason why we've spun out into the epidemic of opioids as we've seen now. Next slide. One of the last parts of the why was the final part was something that we call the patient satisfaction score. And if you've gone to see your doctor or to a hospital recently, you might have received one of these in the mail. And this is not a bad business model. Certainly, we all want to know how we're doing when we deliver health care. But some of the questions on these patient satisfaction scores were very specific to the treatment of pain. They would ask questions such as, well, did they ask you about your pain? Yes or no? And you would answer. And then they would say, well, if they asked you about it and you had it, did they treat you appropriately? And on the surface, that sounds like a very benign question. But if you're an addict, really, what is that question asking you? The question is asking you, well, did they ask you about your pain and you told them you did have pain? So did they get you high? Did they give you enough pain medication to create a euphoric feeling? And of course, if they didn't do that because they're practicing really moral, the morality in when they practice their health care or their medicine, then it was real easy for the patient to then be dissatisfied through the satisfaction survey of the care they received. And ultimately, it led to even Medicaid and the Centers for Medical Reimbursement federally to say, if you've got bad patient satisfaction scores, then we're not going to reimburse you for your health care, which as a clinician puts me in a very, very bad position. I've got to make a decision about doing what is really right, morally, ethically right, versus getting a bad patient satisfaction score and having the potential of being reimbursed for the visit from the insurance company. And so that also created a pretty substantial reason why we have now spun into the opioid epidemic. Next slide. So this created what I call the perfect storm. The perfect storm had to do with a decrease in prescription narcotics on the street because of the prescription monitoring program, a decrease in the sentencing for heroin, inviting heroin dealers, illicit drug dealers to Louisiana in order for them to sell their drug. And if they did get caught, it wasn't that bad of a punishment. And of course, and this created a huge opportunity for the businessman drug dealer to subsequently come on the scene and create an impact in providing this deadly drug for people who really are suffering from their addiction disorder. Next slide. So a couple of things that are important to note here as we take our discussion a little bit further. Heroin dealers are rarely heroin users. And it's important for you to understand that. And I'll give you an example. A lot of times people will sell marijuana, but they also use marijuana. Even with the stimulants like amphetamines and cocaine, people will sell amphetamines and cocaine, but they'll also use it as well. When it comes to heroin dealers, they're rarely heroin users. And what I mean by that is the high-end dealer, the one that's moving a lot of this drug product into our country, they wouldn't use the drug, because if they use the drug, then fundamentally and ultimately, they would probably use up all their product because they would become addicted to it. You have to remember, in this scenario, the drug dealer is a businessman. They're there to sell drugs, and obviously they're the bad guy in our scenario. The good guy in our scenario, of course, is the user. And you got to remember, the user is not only medically addicted, meaning their body physically needs it, but they're also have a psychological illness related to their addiction. And that plays a role when we talk about treatment in a couple of more slides. Next slide. So the bad guy in Louisiana, they're in the business to make money. That's it. They don't care about the people they're selling the drug to. If they die, there's several others waiting in line for them to sell their drug to. They're selling a product that's really in high demand. So a lot of people in this country have become addicted to opioids and will do nearly anything to get their fix from their opioids. They can no longer get it through the primary healthcare model. Then they have to move illicitly to the street, and we can have seen already in our discussion how dangerous that is. They got a customer base that'll do anything to get the drug. These folks are these patients, the good guys, the folks that are addicted, the users. They're the ones that are really ultimately going to need our help when we start talking about solutions. The next sentence I like a lot because, go back one, please. I'm sorry. They're looking for an environment with a high return on investment and minimal laws that make business risk averse. So if that sounds like an economics 101 statement, it really is. But I want you to realize what we're talking about here. We're talking about drug dealing, and drug dealing is a business. People are there to make money. And of course, the bad guy does have questionable ethics. Next slide. A little bit more about the bad guy in Louisiana. They're not making as much money anymore on the stimulant sales. So therefore, they've changed their model because it's more financially lucrative to sell opioids, specifically in our example, heroin. They're not really sure about their business model, and that's why you see these varying degrees of potency. Over the genesis of the cocaine wars that occurred in the 1980s, the cocaine dealers became very good at taking a 100% potent product and reducing it down to less than a 10% product, really what they call cutting the drug. And they were very good at that. They're not very good at cutting heroin. So ultimately, the batch of heroin can be very, very different in its potency. And obviously, we've understand about potency. If potency is really high, it can really affect the user. Of course, if the bad guy gets caught, especially in Louisiana, because we've changed our laws, they're going to go to jail sentence that's very minimal. I'm pleased to say since the beginning of the opiate epidemic in 2012, when the laws had reduced sentencing for heroin distribution from life in prison all the way down to 5 years, we've now bumped that up to 28 years in prison. So we're a little bit higher. We're not back to where we were, but hopefully some of that can help with mitigating some of the issues we're having. And of course, the bad guys got very creative. You remember that slide I showed you at the very beginning of the needle and the spoon? We have other forms of distribution now. You don't have to put a needle in your arm to shoot heroin. You can actually ingest it by snorting it. You can smoke it. You can even press it into a pill and take it orally. Now, the effects are different depending on how you ingest it. So obviously, if you ingest something orally, it has much less effect than if you were to directly inject it into your vein. But the point is because we've gotten creative, the drug dealers have gotten creative in their forms of distribution, there's now an opportunity, a larger market of individuals who can consume it in different ways. Next slide. So let's talk about the good guy real quick, the patient. In almost every case that I've ever investigated, I'm able to repiece where their addiction began. And their addiction began through an opioid prescription provided by a healthcare provider. meaning it was legitimate. They had a neck or a back or an extremity injury. They saw a physician. The physician gave them the prescription, which a lot of physicians thought was safe. And the next thing you know, the person has fallen in love with the drug and want more and more and more of it because they're looking for that euphoric feeling that's created by the opioid. Because of the advent of the PMP, when they no longer were able to go back to their physician and get the prescription, they turned to the street. And there was a time for a while when you could still get the prescription on the street. However, since the PMP or the advent of the PMP and the use of the PMP, we have created an environment where those prescriptions on the street are very rare. And if they do exist on the street, they're very costly. But what's waiting on the sidelines and what is incredibly cheap is heroin. And so that has become the new alternative, is to use the illicit drugs like heroin and fentanyl. And then obviously for our good guy and our patient is if they abuse this long enough, they eventually encounter a drug that's so potent or their tolerance is so low that they ultimately have respiratory failure, central nervous system failure, and death is followed. Next slide. So what are the solutions? And the solutions are not simple. They're very complicated. What's important to remember is the opiate epidemic just didn't start on a day. This had developed over many, many, many years that led to the beginning of the opiate epidemic. So where is the end of the epidemic? The end of the epidemic will occur many, 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 many years from now. But there are a lot of things that we need to put in place now to start helping with this epidemic. One of the first things we can do, and be rather easy, would be to stop using the pain scale. Remember I said the pain scale is not objective, it's subjective. What would be a more appropriate thing is for the medical and the healthcare community to have a conversation with a patient and say, are you having any pain? The answer is not a number. The answer is not a number out of 10. The answer is yes or no. If it happens to be no, then there's the end of conversation. But if it is yes, then the opportunity arises for the healthcare provider and the patient to have a conversation about what the best plan is. And the best plan doesn't necessarily have to be an opioid prescription. It might be something like massage therapy, might be physical therapy, it might be acupuncture. It could be non-steroidal anti-inflammatory medications. It could be steroids. There could be a lot of different things. It might be even a small, very few days of an opioid pill, but not a whole bunch. So that becomes very important. Opioid education and prevention is another solution. And this is one of the big things that was impacted by COVID. The speech you're hearing right now, this talk that I'm giving, I was giving regularly up until the COVID pandemic began in 2020, in the spring of 2020. Probably talking about the opioid epidemic at least once weekly, if not multiple times, educating the community. And I was always surprised how many times I would give the speech, give the talk, and somebody in the audience would act as if they never heard about the opiate epidemic. And of course, that surprised me because I was talking about it so much, but there were still a lot of individuals that weren't aware of how big this epidemic is and was and still is. And one of the things that happened during COVID was, well, we just stopped talking about it. I mean, everything that you heard on the media, the news, the radio, what's in the newspaper was COVID, COVID, COVID. Meanwhile, that didn't mean the opiate epidemic just went away. As a matter of fact, it was simultaneously getting worse, and the numbers have proven that. So I'm glad to be speaking to you today for a lot of reasons, but one specifically is that we can get back to talking about the opiate epidemic, educating the community, and that way it's a form of prevention. By educating the community, we certainly pass this information on so that other individuals can benefit from it and hopefully get people who need help the help they need. Another solution would be increased sentencing of distribution or managing the bad guy. These are bad people. A lot of people say, well, drugs are there's a non-violent criminal offense. Well, I disagree when it comes to opioids. What I see as the corner of this parish is opioids kill people, and they kill people just like guns and knives kill people, just like driving impaired kills people. They are deadly. They are violent. And so I think the sentencing for the people that sell these drugs should be just as strenuous as we would put on someone who committed murder. And so we have to really look at that, specifically when it comes to opioids. I'm not talking about other drugs in this scenario. I'm specifically talking about opioids. Remember, we want to make the bad guy in Louisiana go somewhere else. We can only impact our circle. And so if it's our choice, we would rather them not sell their illicit drugs in Louisiana. Go to another state for that business. Don't set it up here because we're trying to save our populace. The other part could be what's called responsible prescribing. And I'm happy to say that in 2015, 2016, 2017, I was part of an effort in Louisiana to start to curtail some of the healthcare habits that have been created over the time when it comes to prescribing opioids. And you can see right there, and later on, if you wish to look those up, Act 82 and Act 76. Basically, we looked at current legislation and amended it so that we could say, you know what, we have to put some limitations on prescriptions, specifically if we're not treating end of life or palliative pain, meaning palliative care. Someone's got terminal cancer. We certainly don't want to limit their ability to have pain medication. We're talking about people with acute pain, people that have a recent injury. What would that look like? And essentially what we established was, first of all, before you wrote a patient a prescription for an opioid, you had to inform them and let them know that the prescription you were about to write them is very dangerous. It's highly addictive. That way, the patient would have an opportunity to decide whether they wanted it at all. The second thing for acute pain was you could only write the prescription for 7 days and no more. And that became very important because what we were noticing when we looked at what was happening is people were going home from their healthcare provider with buckets and buckets of opioids. And of course, if the person was not addicted to them, they barely used any of them. They might use 1 or 2 of the pills to get them through the really acute process of the pain, and then the rest just stayed in their house, or maybe got thrown in the trash, or maybe got abused by someone who was addicted to them. Conversely to that, if you sent a bucket of this opioid home with someone and they were an addict, well, guess what? They used the whole bucket, and that's dangerous as well. So we had to really put some limits on that. The rest of the responsible prescribing laws has to do with the pharmacy. When the individual brought the prescription to the pharmacy, again, they were warned that the prescription was an opioid. The opioid is dangerous and deadly, can cause addiction and death. So they got warned twice. Again, to hopefully have the patient say, you know, maybe I don't want this drug. Maybe I should try something different. The pharmacist could also allow a partial fill. So if the prescription was for 7 days, then the patient can say, well, maybe I'll just take 3 days in case I need it. So they go home with a lower quantity of pills. Of course, if they needed the additional 4 days, they could always go back to the same pharmacist and get the remainder of the prescription. But nonetheless, preventing more and more pills from being on the street was the purpose. And lastly, every prescriber in the state of Louisiana to this point has been required to go through responsible prescribing habits through continuing education, as well as understanding opioids and the opiate epidemic. So physicians now understand, or anybody that writes prescriptions now understand the impact that prescribing too much has. And so Louisiana became one of the first states in the country to have these sort of laws and pioneering and leading the way. And I don't know that we've seen the benefits of this quite yet, but it will take some time, and I think there will be benefits overall. The last part of one of our solutions, of course, is is probably the hardest part, to be quite honest with you, and it's how do we treat the person who's addicted? How do we treat the patient, the good guy in our scenario? And it's important to remember that they have 2 problems. Number one, they're physically addicted to the drug. Therefore, they need medically assisted treatment to get off of the drug. And we do that through drugs like Suboxone, or methadone's an old way, but nonetheless, a drug that helps them get off the medication so that they eventually get to a point where they're not on any opioid at all. Secondly, the other part that has to be treated is their psychological illness. Obviously, they have an addiction disorder that needs to be addressed, and we address that through something called cognitive behavioral therapy, a way that mentally they can work on why they're addicted to it. Because right now, you know, as a healthcare provider, I cannot look into the lobby of an emergency room and pick the individual that's going to be addicted versus the one that's not going to be addicted. There's no outward sign of that. So we have to be very cautious in how we prescribe. And what's important about the treatment of the addiction is you have to use both of these modalities. You have to use the physical and the psychological component, because if you use one or the other, your incidence of failure is very high. The second complication to this is it's not cookie cutter. And what I mean by that is if you suffer from high blood pressure, you can come see me as a healthcare provider. I can write you a prescription for blood pressure medication, check you back in 6 weeks. And if your blood pressure is normalized, then you're good to go. You probably will be on that medication, and we'll talk about diet and exercise and things like that. But it's somewhat cookie cutter when it comes to that disease process. This is a disease process that is not cookie cutter at all, meaning that if we physically through medically assisted treatment get you off of the opioid, the cognitive behavioral therapy, you may need 6 months of it. You may need a year of it. You may need the rest of your life for it. It is different for every individual, and that, of course, makes, again, the solution complicated. And the other thing you got to remember is when we talk about these two entities, they are costly, cost money. And so you ask yourself, well, where are we going to get the money to pay for all this? And I think there's a good source, and that source is, of course, recently over the past couple of years, you've seen how the pharmaceutical companies have now all been sued, and eventually there will be a payout, much like there was in the tobacco lawsuits. And when that money comes back into the state, into the local community, the most important thing we can do with it is treat the addict, get them the medically assisted treatment and the cognitive behavioral therapy that they need to become opioid free. And I think that's where I would recommend that we spend the vast majority of that money. Next slide. So there's a chapter 2 to our story, and that chapter is called fentanyl, another drug that you might have heard of. I spent a long time talking about heroin, but I will quickly tell you the story of fentanyl. I was on a drug scene, and it clearly looked like a drug scene. It was a locked room. The individual had all the signs and symptoms that we see through an investigation. There was drug overdose. There was white powder on the nightstand. And we had the opportunity to talk to one of the individual's siblings, the deceased individual's siblings. And she said to me, she said, we knew one day cocaine would finally get him, is what she said. And I'll never remember that. I'll always remember that because I kept thinking to myself, and wow, well, I would use that as a clue. I'm trying to investigate why this individual died. It clearly looks like a drug overdose based on the scene. We're going to run toxicology, but she just gave me a clue. In that toxicology, what I should find is cocaine. And so we drew the blood and the urine specimens, and about 21 days later, which is how long toxicology takes, we got those specimens back in our the reports back from the laboratory. And lo and behold, there was only one drug in this guy's system. And I remember how earlier in the presentation I told you that's kind of unusual. People usually abuse a lot of different drugs. Well, the one drug in his system was not cocaine. That's what we were expecting it to be. But the one drug in his system was a drug called fentanyl. And I found that to be very odd because here's a guy who had abused cocaine his entire life. And so you're telling me on a Wednesday, he just decided, well, I'm not going to use cocaine anymore. I'm going to use fentanyl, which is completely in the opposite direction of the effect that the drug, he would be using the drug for. Of course, he had a massive overdose and died as a result of it, which is the tragic part of the story. But it got me to thinking that he probably didn't know the drug that he was getting. And I would even go as far to say that maybe even the drug dealer didn't even know the drug he was selling. It was a white powder. And when the guy walked in and said, I'd like some cocaine, and the drug dealer said, here's some white powder, and he went home and he used it and had a massive fentanyl overdose as a result of it. So having told you this story, I wanted to go back and kind of see, well, we knew heroin came on the scene in East Baton Rouge Parish in 2012. When did fentanyl show up, and what does fentanyl look like today? So next slide, please. So that's the story I basically just told you. So we can go to the next slide. So let's remember our charts. Here's heroin, and you can see back in 2012, 2013, the yellow being fentanyl. There was no fentanyl those 2 years. Next slide. Same chart you saw before, 2016 to 2019. I can go one more. I think it'll give us the totals. There we go. And so basically in 2016, we start to see a little fentanyl come on the scene, and then it takes a tremendous jump. Oh, back one, please. And then it takes a tremendous jump in 2019. What I've included there in red was one of the big phenomena that we saw. Not only has fentanyl come on the scene, but then in 2019, we started seeing a tremendous amount of heroin mixed with fentanyl. And you can see those 29 cases that occurred in 2019. Why is this important? Well, when you have two very powerful opioids, such as heroin and fentanyl, and you put them together, it makes them incredibly deadly, incredibly powerful, and creates a pretty tragic phenomena when those go together. Now, I haven't listed the 2020 data yet because it's not complete, but I will tell you what is currently happening as we move closer or on to 2020. What we're seeing is less and less heroin in the community and more fentanyl. Fentanyl is much, much more powerful because it takes less volume of the drug to create such a euphoric and powerful effect. It becomes easier for people to smuggle across the border into the country, and understand this. This is not a political statement. The drugs, the opioids that come to this country come from Mexico. Period. Plain and simple. A lot of people think, oh well, I've seen the opium or the opium fields of Afghanistan. No, most of the heroin and illicit drugs like fentanyl come in through Eastern Europe if it's from Afghanistan. But we're getting our massive opioid egress into this country through our southern border. The other thing to understand about fentanyl as compared to heroin requires Mother Nature to grow. They actually have to cultivate the opium, the poppy, in a field. They're requiring sunlight. They're requiring water and irrigation. Fentanyl, illicit fentanyl, is synthetic. It's made in a laboratory. So all you need is a laboratory and a chemist and the right chemicals, and boom, you've got fentanyl. So it's much, much easier to manufacture when you take Mother Nature out of the equation. So what we've seen in 2020 is not only a almost doubling, and it might even be a double by the time we get the final numbers in. Like I said, 236 was year to date, was still several cases pending toxicology, but it may push us up to about 250, which would double our last year's record and be the most dangerous, the most deadly overdose year in the history of East Benders Parish. But the majority of that, when it comes to opioids, is not a result of heroin anymore, but more so a result of fentanyl. We still see a little heroin now and then, but fentanyl is the major culprit in this. So lastly, what I want to talk about is how did COVID affect all this? And I think one of the first things that I've mentioned already, which was if COVID, the effect of COVID had to do first and foremost with, well, we stopped educating and bringing to light the fact that we were in the midst of an epidemic, and it's the opioid epidemic. And when we stopped talking about it, then people had less awareness of it. Secondly, COVID did some phenomenal, interesting things as a result to the way we seek healthcare. For example, most people would recognize the emergency department as a place where you go because you need life-saving measures. They're open 24 hours, 7 days a week, 365 days a year in order to be there to help you. And all of a sudden, the emergency department became a very scary place to go because the presumption was that's where the COVID patients were. So people having heart attacks and strokes might not necessarily rush to the emergency room as a result of the COVID pandemic. And so I think that phenomena held true when people were trying to seek care for their addiction issues, meaning that the normal group sessions that they would go to, those were no longer meeting. If they didn't have the technology associated where they could get on a Zoom conference, then they didn't have that support structure that existed. They might not be able to see their addiction specialist, their social worker, their healthcare provider, anyone who could help them as they go through the process of their addiction. And so because of the lack of that interaction that was essentially shut down by things such as quarantining and so forth, it really limited this patient population from having access. And so I think that created another issue related to COVID. And then obviously the last issue, and I think this is the obvious issue, is the tremendous amount of stress that being in this pandemic has caused, whether that's related to your job, whether that's related to your home life. Certainly all those things I think would play a tremendous role, especially a person who's suffering from an addiction disorder. If you don't have access to your support network any longer, that certainly puts you in a precarious situation if you're addicted to these medications. And so I think that is the obvious role COVID played in seeing the increase, the tremendous increase in our overdose numbers in 2020. So having said that, that's the end of the discussion today. I know we're done a little bit early, but I see there's some questions or comments in the side, and certainly I don't mind reading through there and seeing if there are some I can answer, or I don't know if we have a scheduled question and answer session. The question is fentanyl cheaper? Both heroin and fentanyl, both the illicit drugs, are much, much cheaper than getting an opioid prescription. The going rate, let's say, for example, a Lortab, Norco, a hydrocodone, 10 milligrams used to be $1 per milligram. So back before the prescription monitoring program, you could go get a Lortab 10 for $10, $1 a milligram. And now that's upwards of $60 or $70 just for that one pill. And so that's another reason financially why people who can't afford that then will turn to heroin and fentanyl and spend their $10 getting a baggie of a very, very potent, very, very dangerous drug. Does the vital signs go up when they are in pain? They can, yes, certainly. When you're in pain, you can your heart rate can sometimes go up, but it's not always true of those things. Now, the second part of the question is, well, if the person is addicted, are they truly in pain? Certainly, they could be. Pain is a funny thing because what makes pain interesting is the fact that some of it's in our head, and some of it's very different for different people. As an emergency medicine doctor, obviously, I've seen some very traumatic incidences in my career, some of which people had no pain at all, where I expected them to have tremendous pain. Other people have, stubbed a toe or, partially avulsed a fingernail, and you would have thought they were, bleeding to death, kind of level of pain. So it is very different, very subjective for everybody. That's why I think it's very important when there's a conversation between a healthcare provider and pain, that it's a conversation. It's not just picking a number off of a scale and a knee-jerk response of a bucket of opioids to cure that. Anybody else?
Hey, Dr. Clark. Yeah, sometimes there is a little lag on the YouTube. It takes like a minute.
Okay.
So they're seeing what we said a minute ago. But I think we answered all the questions we had in the chat. This was fantastic. It's very interesting. Oh, here's one.
So there's a question that says, how long is one in treatment with medically assisted treatment and cognitive behavioral therapy? So we'll take two parts of that. Medically assisted treatment on the fast end, you can detox somebody within about 6 weeks on medically assisted treatment. Essentially what you're doing is they're no longer getting the short-term opioid that they're used to, whether that's illicit heroin and fentanyl, whether it's prescription opioids, and they're getting a long-term opioid, some of which have an effect that allows them to basically come off of their opioid addiction, their opioid tolerance over time. But eventually they get to zero, where they're not taking any opioids at all. That is the goal of medically assisted treatment. Following that, we move into cognitive behavioral therapy. And that's pretty open-ended because, how someone's brain or mind works will be could be different from person to person. So cognitive behavioral therapy may take 6 months, may take 6 years. It's different for everybody. And that's what makes it expensive, is because it's not cookie cutter. How can we find out more about the PMP? I would go to the Louisiana Board of Pharmacy website. If you are a prescriber, you are every prescriber when you apply for your state narcotics license, does get a login to the prescription monitoring program, and you are required to check it if you are going to write narcotic prescriptions. That's part of those responsible prescribing laws I mentioned earlier. So if you're not a prescriber, then you don't have access to it. It's a tool used by prescribers. Can you feel the effects of fentanyl through touch instead of injection? Yes, absolutely. There's a transdermal component to some of these drugs. However, it may not be as easily as it would be if injecting it. So think about it. If you take a pill, you get one response. If you snort or smoke something, it's a different response. It has to do with the ability to get this into the blood and specifically cross the blood-brain barrier, where it goes into the blood of your neuro system in order for you to start to feel those euphoric effects.
I think that was all the questions we have. Everybody is in agreement. This was an amazing presentation. Thank you so much. Really, really, really appreciated it. So yeah, lots of thanks in the chat for you.
Thanks. Thank you.
I'm going to end this broadcast. If anybody else has any questions, oh, here you go. With data on the pandemic.
Increased the number. Well, I think the pandemic has definitely increased the numbers of overdoses and had a corollary. And we don't have much treatment data currently at this point because we were almost right before COVID hit. We were almost in the stages where we were about to start receiving these fundings where we could push into the MAT and the cognitive behavioral therapy world. So obviously, like everything else, that got delayed. And so hopefully we can kind of pick things back up, especially now that we have a vaccine for COVID that people, you should consider getting if it's appropriate for you, and that way we can start getting back to a life where I'm having this conversation in front of you rather than on the Zoom conference.
Perfect. Thank you so much. And I'm going to go ahead and end this broadcast. But thanks to everybody for your time, and thanks again, Dr. Clark. Really appreciate it.
Okay.